Hello and welcome to the last of the webinars, End of Life Care. My name is Mike Smith, and I'm a clinical associate professor at the University of Michigan College of Pharmacy, and I practice in the inpatient and outpatient palliative care setting. What we'll be discussing today is end of life care and how do we manage symptoms for patients no matter where they're at. So by the end of this presentation, you should be able to describe the common symptoms experienced during end of life in patients with cancer, explore ways to manage those end of life care symptoms, and identify new approaches to symptom management, thinking a little bit outside the box and getting the drugs to patients the way that they need them, whether that's a change in route or change in drug, or matching up the mechanisms, kind of like we did in the previous presentations. What we have found based on studies is that there's certain things that are very important to patients when they're dealing with their end of life. A systematic review of patients who died in the hospital, but it's still probably broadly applicable, they found that there was really four things that were important to these patients. One was effective communication and shared decision-making. Patients and their families want to know clearly what is going to happen, and they want to be a part of those decisions. And in terms of how those things are managed, where they wish to die, what their goals of care are. They want to be heard most often, and they want to know that who's ever caring for them cares for them. The second thing that is common among these patients is they want expert care. And that expert care can be delivered by anybody. It's really about communicating what that care is going to look like. That's when patients feel as though they're getting the best care. They want that care to be respectful and compassionate. And so what you're trying to do when you're taking care of patients in the last months to weeks to hours of their life is give them the care that they have determined is best for them. So listening to what their goals are, what is most important to them. That can be as simple as where do they wish to spend that time? Do they want to spend more of that time in the hospital? Do they want to spend their last hours to days in the hospital, or do they want to spend it at home? If they want to spend it at home, how do we deliver all of the resources available to them in that home? Do they want to no longer go to appointments? Do they want to continue to go to appointments? That decision should be up to each patient, and respecting those decisions and helping them live the life that they want while they have one, and making it as quality as possible is important. The last thing that they want is they want to be able to trust and have confidence in their clinicians. And so they want to know that you're making those sound decisions, and we'll kind of give some tips of how to talk to patients about different things, and to make sure you're choosing the right drugs for the right symptoms that these patients are likely to experience at that point. When we talk about symptoms, it's important to really think about what those symptoms are likely to be so that you can anticipate them and stay ahead of them. We often find that it is most easy to manage symptoms if you're in front of them. If you're playing catch up, you're often playing catch up until it's too late. And so there was a study done that looked at what are the most common symptoms of patients that were signs of impending death, and then their common symptoms. And so this study looked at this review looked at 12 articles, had over 2,000 patients in those articles, and they looked at across all settings. And of the 43 unique symptoms that were reported across all of these studies, the highest prevalence of these were shortness of breath in over half of the patients, pain in over half of the patients, respiratory secretions, or what is commonly referred to as the death rattle, but I'd tell you not to refer to that for patients, in over half of patients, and confusion in just about half of patients. So when you're talking to patients about what is to come, what will these things look like, it's important to shift that conversation as time passes. And so we know that many symptoms in cancer are going to be present earlier on, and they're likely to get better with treatment or with symptom management, while some present later and tend to get worse regardless of what we're doing for them. So the ones that we'll really focus in on today are pain, shortness of breath, fatigue or drowsiness, nausea and vomiting, constipation, loss of appetite, and delirium. And we know that some of these improve over the last week to hours, and some worsen. Pain and nausea actually tend to improve over that period of time. likely to, drug accumulation, and we've gotten on top of that. And those tend to be the things that we're most comfortable managing, while things like fatigue and drowsiness and agitation tend to worsen. And that goes along the lines of what's happening to the patient's body. Fatigue is just something that happens, and we don't really have great medications for that or great things that we can do to that. Drowsiness is often a result of treating that pain fairly aggressively. And agitation is primarily due to disease, although it can also be due to drugs that we're using for other things. And so those things tend to worsen. So having that picture in your mind that these are the ones that worsen might help you try to anticipate how you can treat them better, and also to talk to patients about them and saying things like, we expect that you will experience X, Y, or Z symptom. We will be in front of them, but it's important for you to recognize what those signs and symptoms are of those symptoms and be upfront so that we can get in front of those symptoms. And having that communication to patient and caregiver and family will help those lines of communication be open and helping manage those symptoms wherever that patient wants those symptoms to be managed. So in one of the previous webinars, and if you haven't watched all of those, I would recommend that you watch all of those, pause this here, go back and watch all of those, and make this the last one, because we talk much more in depth about pain in the previous presentation, and we're not going to talk about it in depth in this one, but we're going to talk about some other things that you might want to consider. And we're talking about the kitchen sink here and things that we should be considering for patients, although you could consider these much earlier for patients. So go watch that pain presentation if you haven't already and get through all of that. Then come here and look at these options. So these are things that you might want to consider for patients when you're having trouble managing their pain. So oftentimes, oral ketamine is an effective drug. Oral ketamine does not actually exist as a product. It is simply the intravenous version given in an oral syringe. What's helpful for patients is mixing that with juice of any sort. It doesn't really matter, or a flavoring. Patients prefer that. They can even just use a little bit of sugar or a hard candy before taking it. It's not a terribly tasting medication, but anything that gets the drug to go down is helpful. When you're looking at starting somebody on oral ketamine who's never had it before, a general rule of thumb is 0.5 milligram per kilogram divided out 3 times a day. So generally you're looking at about 15 to 20 milligrams 3 times a day in that range. And you can up titrate this rapidly as needed. So we will often up titrate it 5 milligrams per dose every day. So if I start somebody at 15 milligrams 3 times a day, I'll give that to them for 1 day. Day 2 will be 20 milligrams 3 times a day. Day 3 will be 25 milligrams 3 times a day, and rapidly up titrating that until you either see a side effect or you see pain relief. Most often we're seeing pain relief when you're getting to about 30 milligrams TID. If you're getting above 50 to 60 milligrams 3 times a day, you should be thinking about other things. But luckily you can get to that in a week, and so it doesn't take a lot of time to get to the dose where you're kind of maxing that drug out. Something to be mindful of when you start patients on ketamine is that they can have hallucinations, so making sure that a benzodiazepine is available for that. That shouldn't be a reason to stop the drug. If it's working, you can treat those. Some patients will also have excess oral secretions from that as well, and you can treat that just like you would any oral secretion. Mexiletine is an antiarrhythmic, but it's a sodium channel blocker. It's basically the oral version of lidocaine. Now, the studies that have been out there have really primarily focused on patients that have shown response to lidocaine that are then switched to mexiletine. That doesn't mean that's the only time that's effective, but that is where the studies lie. Now, if I'm having a patient who's having significant neuropathic pain, and I have hit all of those receptors that we talked about in the previous slides, and I'm looking for a sodium channel blocker, mexiletine would be a reasonable option. So would the next one, which is topiramate. I'm trying to find ways to block as many of those receptors as I possibly can. The difference here between mexiletine and topiramate, when you might use one versus the other, is mexiletine is an antiarrhythmic, so anybody with significant cardiovascular disease you need to be mindful of, versus topiramate can cause weight loss. So certainly not ideal in patients with cancer if they have cachexia, but an option for them. It tends to be a little bit of a pick-me-up as well. So if I have somebody that's a little bit fatigued, I'll consider the use of topiramate over mexiletine in that option. And then certainly buprenorphine. Buprenorphine, as we've talked in other presentations, is a partial mu agonist. It's a kappa antagonist or an inverse agonist. And so its safety profile is better than other opioids. The only time you might want to consider using this is if you've got an opioid naive patient who you want to start on a long-acting drug and you're concerned about oral administration. All right, so you could start a Butrans patch, or if their oral morphine equivalents are relatively low, you could put them on sublingual buprenorphine. The advantage of buprenorphine in patients towards the end of life is the different routes of administration. So it can be given buccally, it can be given sublingually, and it can be given transdermally. The difficulty would be switching a patient to buprenorphine. Now, most cancer patients towards the end of life tend to be on high-dose opioids, and that wouldn't be a switch that I would be making in that case. But if somebody is using, let's say, 50 to 60 oral morphine equivalents or less, this might be an option if I'm concerned about dysphagia or their inability to swallow moving forward, and I can take advantage of some of those other routes. It's a long-acting medication. The patch is only changed once a week. The buccal film and the sublingual can be dosed 2 to 3 times a day. But think about when you're managing somebody's pain, go back to that other presentation and how do we hit all the receptors that we need to? And then as they're transitioning at end of life, how do we continue to give them drug that we need to give to them based on whatever route of administration we may need to get to. The next significant one is shortness of breath. And this one I put towards the top of the list because it's often not thought of as a way to manage easily, but there's a good amount of data that using non-pharmacologic therapy in these patients is very effective. And so I listed a few here for you, such as fan therapy, non-invasive positive pressure ventilation, or even things like acupressure or reflexology. These things have been shown to improve shortness of breath in patients, in particular, cancer patients. There was a systematic review that included 29 randomized control trials that had more than 2,400 patients. And they looked at these various interventions. Some of them were combined with others depending on the trial. Some were done individually compared to nothing or compared to standard of care. And the ones that I listed here for you were actually associated with improved breathlessness. And that lasted for a few minutes to hours in different settings. And so these are things that you can give to patients that are easy. Some of them, there's nothing to do. Acupressure, you teach patients how to do acupressure, or have them go to somebody that can do some reflexology. Fan therapy can be as simple as a handheld fan or a ceiling fan. It's really that circulation of air. And it's really interesting. I think it's not really thought of how does this actually work. But the way that I try to explain it to patients is, have you ever ridden on a roller coaster and you've opened your mouth? When you opened your mouth, you probably gasped for air because you've got that giant rush of air. What that is doing is that's really fooling your brain. It's really making your brain think, whoa, there's too much air, close your mouth. That same process is happening for fan therapy, where there are receptors on the face that once that air is crossing the face, it's telling the brain that, hey, there is air moving. You don't need to be short of breath. It's not really doing anything other than kind of fooling the brain and having the brain think that there is air available, you're not short of breath. This data goes back to the 1950s, where they had patients in a very interesting study where they just had them hold their breath for as long as possible and to then breathe when they needed to. And what they looked at after this is then they had them take several breaths of a mix of hypoxic and hypercapnic gas. So if you're holding your breath, you're going to become hypoxic and hypercapnic. So they had them hold their breath, then they had them inhale gas that only made that gas exchange worse, but they felt better for doing that. And so really what that shows is that there is a way to trick the brain because of that, because what you're doing in those circumstances is you're actually activating stretch receptors. And so these various therapies are doing this in different ways, and opioids are doing it the same way as the others. Is they're not The purpose is not to drive down somebody's respiratory rate. The purpose is to calm the feeling of shortness of breath. You're not going to be able to get people to run a marathon or walk long distances, but you're going to alleviate that feeling of shortness of breath. That's the whole purpose of this. For patients that are on opioids already, you may be asking questions along the lines of, when you take your opioid, do you feel less short of breath? When shortness of breath is a little bit more difficult to treat is when patients have an underlying anxiety with this. So we often more see this in patients with COPD, but patients with lung cancer can present with this as well. So is it anxiety that's leading to shortness of breath that's leading to more anxiety? Or is it shortness of breath that's leading to anxiety that's leading to more shortness of breath? Teasing that out in questions will tell you what you should be treating with. If it is the latter, where it's shortness of breath causing anxiety, no benzodiazepines there, because you need to be treating the shortness of breath. If they have anxiety that's leading to shortness of breath, that tells you need to be treating anxiety first. When you talk to patients for this symptom in particular, realistic goal setting, when we're treating shortness of breath, we're talking about incremental benefits here. You may be able to stand during your shower the entire time, or you may be able to stand a shower for 5 minutes, then need to sit down, whereas before you were unable to shower because you would get short of breath. So find out what their limitations are, then give them realistic 1 or 2 steps above that as to how you'll treat their shortness of breath. Other things that could be tried in a pinch would be something like an inhaled furosemide. There have been some reports of that working. The data is not all that great, but if you're reaching for things, that's not an unreasonable option. Fatigue and drowsiness. So this is one of those symptoms that tends to worsen over time. It tends to be very difficult to improve or to treat to any sort of reasonable improvement. But what you need to tell patients, and in particular their families, is that they'll likely see flashes of improvement here where they're going to have a good day or a good couple of hours where that fatigue and drowsiness goes away. They need to moderate that activity during that period of time. Or they can go, full steam ahead with the understanding that that's going to wear them out more. We commonly see this where there's an ebb and flow, where they get some energy and they try to do too much. But if they moderate that activity, we tend to see less fatigue over that period of time. For ways to treat it, really, there's only 2 at this point that have really shown any benefit. You're looking at corticosteroids and stimulants such as methylphenidate for cancer-related fatigue. But what's often missed is removing any sort of drugs that can be depressing to a system. Commonly seen are beta blockers, and removing a beta blocker can have significant benefits for patients that had some fatigue. So think about drugs that might be slowing them down in any sort of fashion. See if you can get rid of it. But other than that, this is about education around what does fatigue and drowsiness look like for patients. If they're drowsy secondary to drugs, remove them. If they're fatigued from disease, have them moderate activity, give them drugs to help them get through their day and improve their quality of life. Nausea and vomiting. So this was one of the previous presentations that we went into a lot of detail of. So we won't be rehashing any of that here, but what's most important here is staying ahead of it. The faster that you can get on top of somebody's nausea and vomiting, and the harder you can hit it, the better off that patient will be. So get comfortable with those medications and those mechanisms and combinations that are going to make sense for patients. Get more comfortable with olanzapine in particular. We know that there's a lot of good data about chemotherapy-induced nausea and vomiting with olanzapine, but remember from that previous presentation that the binding affinity profile of that drug is very beneficial for patients with cancer and their reasons for nausea and vomiting. And so stay ahead of that. Go watch the presentation again if you need to think through it some more. Constipation. This can be the underlying cause of many symptoms. And so one thing to take a step back for is to think about your patient that's sitting in front of you. What's the cause of their constipation, or what is that constipation causing? Oftentimes, we forget about the long-term ramifications of using opioids. And so opioids obviously cause constipation, but opioids can cause other things like urinary retention or metabolic issues. So don't feel the need to be treating one drug symptoms with another drug. If you can remove drug or minimize it, that will help. But constipation, just like urinary incontinence, can cause things like pain. It can cause agitation. It can cause delirium. So make sure patients are moving their bowels the way that they need to. This should be fairly common for many of you to treat. You can use things like laxatives like polyethylene glycol or milk of mag, or stimulants like bisacodyl or senna, or even enemas. There's a number of different enemas out there. I've listed a few that aren't too bad for patients and their effectiveness. You need to be treating patients for constipation ahead of time, because that can lead to such bad symptoms that we often miss. We see a patient that's agitated and we often forget, have they gone to the bathroom? Have they moved their bowels? When was the last time? Should that be done first? Because remember, treating things like agitation is exceedingly difficult, and this is a common yet easily treatable cause. The next symptom that's fairly common in patients with cancer is a loss of appetite. So this is fairly common, but it's not always bothersome. So if somebody reports it to you, try to understand how important eating or tasting foods is to patients. Some patients do what's called voluntary cessation of eating and drinking, and that is their choice. Some patients, food has been their life, and that is their comfort. So how do we give them not only their appetite, but possibly their taste? So identifying what is behind that and what do they mean by they've lost their appetite. Does it mean that they don't want to eat anymore? Does it mean that they no longer enjoy the foods that they once did? Does it mean they can't taste or smell the foods that they once did? Does it mean that they can no longer eat the quantities of food that they once did? And go after that cause first. So we know that things like corticosteroids and medical marijuana stimulate appetite. Those would be things for patients that I no longer want to eat. It's not enjoyable to me, but they still would like to, but they don't feel the need to anymore. Versus something like miracle fruit, and you can put this into Amazon, and it's something we recommend fairly commonly for patients who have lost their taste. And you can have them play games with it to give them something interesting to do, but to also give them some nutrients. So miracle fruit, it's a tablet that you can just dissolve on your tongue, and it changes the way that foods taste. So as an example, you could tell a patient, why don't you try bites of little different pieces of food after using miracle fruit and see if that's enjoyable to you. One of them you can tell them to do is try to bite a lemon. After using miracle fruit, it actually tastes like that lemon is covered in sugar. And so this would be a fun way for patients to retry some of the things that they used to enjoy and try it in a different way. Delirium. And so we're going to spend some time on delirium here because we know that this is a really complicated process. But what I would encourage you to do is when you're evaluating patients and talking to their caregivers and family is you must differentiate between hypoactive and hyperactive delirium. We know that drugs do not work for hypoactive delirium, but there is a good reason to believe that they do work for hyperactive delirium. The easiest thing that you should do first is remove any sort of offending agent or reason or underlying cause. That's not always possible, but when you can, you should. And then try non-pharmacological measures first. So when it's daytime, lights are on, curtains are open, having family members orient patient to person, place, and time, and talking to them. And then when it's bedtime, it is bedtime. But what you can see by this next slide really is that it's very complicated. And so these are sources of delirium for patients, and they can be significant. And really what you see almost across the board here is that there tends to be a reduced availability of acetylcholine, regardless of the source of delirium. Primarily for patients with cancer, we're looking at the bottom one in medical illness, although in many patients, we're also looking at the second from the top, aging. What we also commonly see across most of these is that there's an excess release of dopamine, which is why we use dopamine antagonists, or we think that those things work, and that there's an excess release of norepinephrine and or glutamate. Unfortunately, we don't really have drugs that work well on those pathways. And then there seems to be some alterations in serotonin. Sometimes it's an increase, sometimes it's a decrease, and then alterations in GABA. So if you think about drugs that are working on these pathways, such as a benzodiazepine and GABA, you may be messing with their neurotransmitters in a way that might not be beneficial for patients. So review the medications that these patients might be on before you start anything to see if you're impacting this pathway any worse. Here's a figure, and the point of this is really not for you to even be able to see it, but these are pathways or causes that then lead to neuronal aging and increases of risks of delirium. And what you can see is that there's no single path. These things are all interconnected. They affect one another. And this is why treating delirium is super, super difficult. It is not something that you can throw a single drug at and expect to work. This is something that we want to try to avoid as best as possible and then try to treat if we can. The way to treat, remember, for hypoactive delirium, as I mentioned a few minutes ago, is drugs don't work, right? So the drugs that we're using for patients with delirium are primarily dopamine antagonists. We are not talking about an excess of dopamine for patients that have hypoactive delirium. Here, you should be treating any sort of reversible cause that there may be and reorienting patients. That's the best that we can do at this time. Unfortunately, there's not much else that we can do. Now, when we talk about hyperactive delirium, it's really all about pharmacology here. So our typical antipsychotics, like chlorpromazine or haloperidol, they block D2 receptors, versus our atypicals start to pick up 5-HT2A antagonism. If you want to get a song stuck in your head and really go after some pharmacology, I put a YouTube video here for you about a psychopharmacology professor who has a catchy tune. I won't play it today because otherwise it'll get stuck in my head for the next week, and I've seen it about 1,000 times. But it's a good video to help you kind of remember what's going to happen if you block D2, what's going to happen if you block 5-HT2A. We'll go through some of that today, but if you want to get a catchy tune stuck in your head, please feel free to watch that. So what we're talking about when you are treating delirium is that you're trying to hit D2 occupancy. And now some of this is related to, dosing antipsychotics for other indications, but it's important to see what kind of doses we're talking about here for that, because if you're treating agitation, you probably don't need to get to super high doses. So when you get between 60 and 80% occupancy at the D2 receptor, what that does is that decreases positive symptoms. So that really is what we're talking about for delirium, is our agitation, and it also avoids EPS. And so these are the doses that generally fall within that occupancy. So you're talking about only 8 milligrams of haloperidol in a day. Oftentimes in the inpatient setting, we're seeing 5 milligrams of haloperidol given every 4 hours, and patients are just getting snowed from that. You're only talking about 2 milligrams twice a day of Risperdal, or even just 15 of olanzapine. So think about the dosing that you're using for these patients, because it probably does not need to be as high as you may be prescribing or you've seen commonly. What you've also see is, depending on whether there's weak or strong binding at various receptors, is you're going to see different side effect profiles. Now, I'm going to pick out a few of the common ones for you here, so that we can talk about what that actually looks like for side effects, but also for what can you expect from those drugs and what should you be counseling patients on. Okay, so let's take a look at some of those. So the top left picture for you, this is your typical antipsychotic. We're primarily getting D2 receptor blockade, and then from there, we're looking at M1, we're looking at histamine, and we're looking at alpha-1. And so what do we see from blocking those various receptors? So if we talk about muscarinic receptors, or M1, the therapeutic effect is that you're minimizing the risk of EPS for those patients. But remember, if you're blocking muscarinic receptors, you're going to get some of that anticholinergic properties. So you're going to get patients that are going to have some constipation, some sedation, or dry mouth. When we look at histamine, those are fairly obvious as well, what histamine effects are. But then think about alpha-1. Alpha-1, this can cause patients to get dizzy or hypotensive. So the stronger that we hit alpha-1, the more likely we are to see some of those, cardiovascular effects for these patients. If you were to think about the drug on the right, I'm not going to tell you what it is just yet, but take a look at what that drug is actually binding. Okay, and so the first one on the top left of that is 5-HT2A. And so 5-HT2A, this drug in particular binds it very tightly. What that does is that reduces our risk of EPS. So that's a good thing. It's not really associated with any sort of side effects. So when we see that across all bottom three, that's a good thing. It hits D3. And so when we're binding D3, this is something that, again, reduces positive symptoms, but also actually works as kind of a mild antidepressant. The next thing that it does here, and it's hard to see in this figure, is 5-HT7. And so this is a drug that you might want to use for patients if they're having circadian rhythm problems. It might help them sleep. 5-HT7 is not in particular associated with any sort of side effects. It has some alpha-1 that we talked about previously. It has 5-HT2C. This tends to be antidepressant. The side effect from that tends to be that it has cardiometabolic effects. That's really something that if you're using this long term, you might be concerned about, but that's really probably not the case for most of you when you're treating patients. And then finally, 5-HT2 or 5-HT1A. And so again, we're talking about this can be an anxiolytic or an antidepressant. So I want you to think about what that drug might be based off of what I've told you. Pause the video for a second and test yourself. And then I'm going to open up and show you what that one is. So that one's risperidone. And so if we think about that drug, you're going to use it for patients that are having hyperactive delirium. Maybe they're having trouble sleeping, or they have comorbid depression or anxiety. That might be a drug that makes sense for those patients. If we go to bottom left, what we're seeing here is now we're only a partial agonist at D2. So we're not as high of a risk of developing EPS versus the others. It has similar binding to risperidone in D3, 5-HT1A, 5-HT7, 5-HT2C, alpha-1. But now we pick up histamine a little bit more in this one. And so take a moment, pause the video, and think about what drug might be picking up histamine in its effects, but be similar to risperidone. I'll show it to you now. And so that drug is actually aripiprazole. So we're not getting much of a benefit from aripiprazole from a binding affinity standpoint. And when we're talking about mode of delivery, you're probably not taking any sort of advantage there. If we look at bottom middle, we're seeing a lot of things binding here. There are a lot of receptors being activated. In comparison to the others, we're seeing less D2 and less D3, but we're seeing things, the histamine and the alpha is much stronger. And then we start to hit M1, but we also pick up muscarinic 3 receptors as well. So in comparison, if you were to think of, okay, I've got risperidone as a drug I'm thinking of, what drug do you use, what antipsychotic do you use that's going to make people sleepier, particularly at lower doses? If you don't want to know the answer, pause to think about it, and then I'll open it up here. That's quetiapine, right? So a drug that we tend to use for patients because we can get them sleepy is quetiapine because of that histamine blockade. So if you're really concerned about somebody who's agitated, who's having issues sleeping, quetiapine might be the drug over risperidone, given that it has better binding at histamine receptors. Then the last one here, we could do this with all of the antipsychotics, but this is the last one that we chose here. What you see is that you have, moderate D2 and D3 binding, but it's much, much better at 5-HT2A. And so that's really reducing our risk of EPS. And then you have moderate binding mostly at every other receptor. So think about a drug that's like risperidone and quetiapine. It's not going to cause people to be as sleepy as quetiapine, but might be a little bit better than risperidone. Pause if you don't want to know the answer, and then I'll be opening up right now. So that's olanzapine, right? And so if we think about drugs and how we're using them to advantages, we would use olanzapine in somebody who maybe they have QTC prolongation because this drug doesn't do it. They might need a little bit of help with sleep, but not. They might be nauseous. Because of that binding profile, you're going to hit many receptors, but not hit them so strongly that you're going to cause things like sedation or too much dopamine antagonism. When you look at the available data and the studies that have been published in the last couple of years, you might want to consider olanzapine, quetiapine, or piprazole first, based on less EPS and various routes that are available. But one thing that's interesting to note in these studies is that haloperidol and risperidone did not seem to be beneficial in cancer patients with mild to moderate delirium. This could have been because of study design and mixing hypo and hyperactive delirium, and it could have been because of small effect size, given that they only had mild to moderate delirium. But one of the drugs that or two of the drugs that you should really be considering kind of at the top of this would be olanzapine and quetiapine, and taking advantage of, do you need more histamine blockade than go after quetiapine, or do you have somebody who's more nauseous, go after using olanzapine, and thinking about how you're going to use those drugs for those patients based on their binding affinity profiles. Anxiety and depression, this was talked about significantly before, so we won't go into all the details of it. I'm just going to hit some highlights for you here and some of the things that we didn't discuss. So remember that adequate trials of antidepressants are 12 weeks. And what we talked about in the previous presentation was that after one round, only about a third of patients go in remission. So if I'm on round 2 and then I need to give them another 12 weeks, we're at 24 weeks before whether or not we know those patients are going to respond. And then we know that only about 20 to 25% of them respond, and then we're at another 12 weeks. So theoretically, it could take you 36 weeks to use 3 drugs, and you're still probably not treating their depression or anxiety all that well. Not many patients that we're talking about in this presentation are going to have 36 weeks ahead of them. So in those cases, you should really be considering adjuvants. Ketamine burst, there's some data that's going to be coming out in the next year or two about using ketamine when starting an SSRI and whether or not it's going to lead to benefits. My hypothesis is it will, because a single dose of IV ketamine seems to have effects for 14 to 28 days, and that's the time when your SSRI or SNRI are starting to get up into a reasonable dose. You could be using corticosteroids. This is really going to be for patients that have fatigue related to their depression. It's not going to be great for people with anxiety necessarily, but using bursts of that, or if they have concomitant pain or comorbid pain, that's a reason. And then stimulants for people that, again, have more fatigue associated with their depression, not necessarily anxiety. And one thing I want to note here is that buspirone can get tossed around by people, but buspirone is not effective for patients with a recent exposure to benzodiazepines. And the reason for this is that there was one study of patients that had generalized anxiety disorder. There was nearly 800 of these patients that were treated with buspirone, a benzodiazepine, or a placebo, and they got divided into groups in this study. And so they had either no benzodiazepine treatment previously, they had recent, meaning less than a month previously, or remote, more than 1 month. And so they followed these patients for a period of time. And what they found was that patient attrition was significantly higher in those that had recent benzodiazepine treatment compared to those with remote or no treatment. And this is likely because of how benzodiazepines make people feel versus how buspirone makes them feel. Not that buspirone is not effective, but for patients that have taken a benzodiazepine recently and they know how that drug makes them feel, they're not going to get the same effect as they are with buspirone. Buspirone would be an effective drug for patients with anxiety without that recent exposure, or with no exposure. But if you've got somebody on the benzo, please don't be adding buspirone on top of that drug. Now, the last section that we're going to end up here, I'm just going to call tricks of the trade. These are things that might be beneficial for patients. They're a little bit different, but things to consider. These are things that I'll often bring up when I'm asked, well, I don't know what to do at this point. What should we be trying? And so I'm going to let you in on some of those secrets. Hopefully they're helpful for you and for your patients. So It's just a list. So consider topical morphine for wounds. This is the easiest compound that patients can do on their own. Give them a 30 milligram immediate release morphine, have them crush it up and put it in their favorite cold cream and apply it to those wounds. It's effective for wounds that do not have any sort of eschar on it. They can be in any sort of healing. And what you'll have them do is put an adsorbent dressing on, so it can't be absorbent, and pull that cream away, or they could leave it open. This would be really good for people who you can't give them systemic opioids for one reason or another. Maybe they have end-stage renal disease. Maybe wounds are their only cause of pain at that period of time. These can even be things like sacral ulcers. There's really little to no systemic absorption when you're using these topical drugs. And because our several layers of skin have opioid receptors, it makes them effective locally. Ketamine as an oral rinse for refractory mucositis. It's super easy for patients. It can be wildly effective. If they swallow it, it doesn't really matter, but they can use it as a rinse. But it's a drug because of the high amount of innervation in our mouth that it can be effective for patients with mucositis. You can buffer it with things if you need to, like salt and soda. But if you're having patients that have mucositis that's otherwise uncontrolled, ketamine might be an option, or even something like adoxepin. I'm going to tell you now to stop using scopolamine, docusate, megestrol, or megase, and anabolic steroids. You can just cut them from your practice completely. So scopolamine, if we're using it for terminal secretions, it has an onset of 12 hours. That's not really going to help anybody, and it doesn't reach steady state till 24 hours. The other problem with that drug is it crosses the blood-brain barrier, and it has an increased risk of delirium. The only time that you might be using scopolamine would be for somebody who you're worried about vestibular causes of nausea and vomiting, and you need a longer-acting drug. That would be the time to use it. If you're talking about terminal secretions, that's not the drug to use. Use something like glycopyrrolate. Docusate, you can just start getting rid of this completely in your practice. It's been shown to simply not work. And so the reason for this is docusate was developed out of diacetyl oxide. And so what that drug requires is that there be water in the bowel to make it work. Think about this for a second. If there's enough water in the bowel to soften the stool, that stool softener is probably not going to do anything because it's really just keeping the water that's in there. Most patients that have constipation like that need water to be pulled into the bowel, so they need something like Miralax. Docusate is probably not going to be enough. Get it out of your practice and just replace everybody that's on it with Miralax. If they are having diarrhea from that Miralax, just cut them down, half a cap or a half cap every other day. Docusate is a drug you can just get rid of. Megestrol, and so we know that cancer patients have more than twice the risk of developing thromboembolism from this drug. It has not been shown to improve weight in any sort of significant fashion other than fluid retention. And then the same goes for anabolic steroids. And I've seen this at various times throughout the years for patients who are trying to improve muscle mass. The bar is really high for improving muscle mass in cancer patients based on FDA standards, but no drugs to date have been able to do that. What you're doing for patients with anabolic steroids is that you are simply putting them at risk of side effects and complications from them rather than really developing any sort of lean muscle mass from them. Patients tend to gain weight on both of these drugs, but it tends to be water weight that goes away as soon as you take that drug away, and it's not beneficial weight. So another thought would be patients that have seizures. So if you're trying to minimize the amount of drugs that patients are on, and you should be deprescribing for patients that are, transitioning to comfort-focused care and they don't need all these drugs. And cocktails of drugs that come up all the time are anti-epileptics. If you're trying to minimize that, you can give them lorazepam concentrate. And so this is fairly simple. You can give them a half to 1 milligram every 6 hours scheduled. If they are having seizures, give them 1 milligram in their buccal cavity every 5 minutes for up to 4 doses until that seizure subsides. But this is an easy thing for family members to do as well. For patients with small bowel obstructions, which can be fairly common in cancer patients towards the end of life, schedule dexamethasone and haloperidol or olanzapine, and if that doesn't work, give them some sub-Q octreotide. Can be super effective. A hint about marijuana and dronabinol is never replace somebody's marijuana use with dronabinol. So when we have patients who are regular users of marijuana, medical or otherwise, they get an upregulated cannabinoid system, endocannabinoid system. Dronabinol is simply synthetic THC. And so when patients are using their marijuana, they're getting THC, but they're also getting the neuroprotective component in CBD. When you have that upregulated system and then you introduce just THC products, those patients tend to just get high. They do not end up having any sort of the benefits from CBD, and it's not beneficial at that point. And then the last thing I'll leave you with here is that to not forget about methadone. Methadone can be used as an adjuvant at low doses. It can be used to replace a long-acting drug. Remember that in any formulation, methadone is long-acting. It's long-acting because it is highly lipophilic and sits in our fat tissue and leaches back out. So that means if you're giving the oral solution, it's long-acting. If you're giving the tablet, it's long-acting. If you're giving it rectally, it's long-acting. And if you're giving it IV, it's still long-acting. It's the only long-acting opioid that we have in all of those formulations. And so if you have patients that are having trouble swallowing pills and they need an alternate route, but also getting a long-acting, if you don't want to go transdermal, you can go with methadone. Thank you for your time. I hope you enjoyed this presentation on end-of-life care.